The information provided in the interviews and on the website of the Autism, ADHD, and Sensory Processing Disorder Summit is for information and educational purposes only. It is not intended to diagnose or treat your child and is not a substitute for working with a qualified practitioner. There are many gifted, passionate, and knowledgeable practitioners with hundreds of hours, if not thousands of hours of clinical experience. Part of our goal is to give you the knowledge and tools you need to effectively advocate for your child. No one knows your child better than you. No one knows your child's history and can better judge what's normal and abnormal for your child. The greatest success in recovery comes with the parent being informed and asking the right questions and making the best decisions for their child in coordination with a team of qualified practitioners in different areas of specialty. Enjoy the summit. I'd like to welcome today to the Autism, ADHD, and Sensory Processing Disorder Summit, Dr. Nikogosian. And I have a trouble with your name, and I don't know why, but there you go. We met actually at the Medical Academy of Pediatric Special Needs, but he's a board certified in internal medicine, a member of the Institute of Functional Medicine, and the Medical Academy of Pediatric Special Needs, or the MAPS organization. Over the span of 15 years, he's gained a broad experience in conventional medicine model as a hospitalist, private practice primary care physician, and a chief of primary care at the Veterans Administration. What I'd like you to start off by telling us, though, is how you got into functional medicine, why you made the switch, and why it's so important to you.
Hello, Tara. How are you doing? So the way I kind of got into it, I started out as a standard primary care doc, and I did that for about 15 years. In around 2010, 2009, 2010, I had a son who was diagnosed with autism, and we went through the usual stages most parents kind of go through, trying to seek help and find out what we could do about it. And frankly, we didn't really get much. We didn't get much answers. We got a lot of we got a lot of what couldn't happen, or what could happen if we were lucky, just by sheer chance or whatnot. But nobody really was looking at my son as if there was something medically wrong with him. And that was just from my conventional training. It really kind of put my feelers up. I'm like, well, he's essentially has a neurological issue. Well, the only part really neurologically they did was they ruled out whether he had seizures or not, which in retrospect, I think they did a great job of that. But there wasn't really much workup. In the end, it was this psychiatric problem that he had to have therapy for, and that was that. Which and then we put him into this therapy, which I think is extremely important. But I couldn't really find anyone in my local community who was really going to help with finding what was the imbalance, what was the physiological issue underlying it. So I took it on myself to research it and learn about it. And I'd always had an interest in integrative and functional medicine for my adult patients, which I was starting to transition that in my regular practice. This journey my son set me on, absolutely supercharged it in terms of, I started discovering all these different things that were going on and with my son as far as different interventions we did. And concurrently, I was doing this with my patients in my practice as well. And in the course of really probably about 18 months to 2 years, I completely changed my practice model. And there was kind of no going back, because frankly, doing a functional medicine integrative model, it's just a better model. I never turned my back on my conventional training. I still think conventional medicine has its place. I think it's very effective in some regards, but it's a tool. And all of a sudden, my toolbox expanded dramatically. So I think that's what really sort of put me on that course. And then invariably, here in Las Vegas, in this community, it's limited, the number of practitioners treating this. There were some that were traveling in, a day a month or something like that. But there's really nobody here regularly. So I started seeing some kids through families that we knew. And then slowly my practice sort of just changed over. We're now, seeing probably about 50% of my practice is autistic kids. and kids with ADHD and other neurodevelopmental problems like sensory processing disorders.
Yeah, and that's amazing. It's amazing how many practitioners I'm sure you ran into too at the MAPS conference that their story is very similar in the sense that they encountered a problem with their own child and then realized that they didn't have a lot in the conventional medical model to help. It's fantastic that you actually now have a clinical practice that surrounds that, because there are so many people that need help. So what we wanted to talk about today was how you have changed your approach to these kids in particular, and what the functional medicine model, a general functional medicine model, allows you to do, and how you look at them and go about determining what the right treatment protocol is for them.
So yeah, there's sort of a general approach that we have, and as you know, and I'm sure a lot of listeners know, I mean, when you have a child who comes in with these disorders, and particularly autism, I would say, where it's probably one of the most complex childhood disorders that we are treating right now, which is chronic in nature. When these kids come in, it's very rarely one thing. Sometimes we get lucky, and it is one thing, we fix the one thing, and those are the kids usually where we get pretty dramatic results in a relatively short time. But usually that's not the case. It's usually multiple issues, because that one thing led to this, 2 other things, which led to 4 other things. And by the time the child presents to us, these problems are pretty well established. But typically we start with the gut. That's the number one thing I always start with. And part of the reason for that is, even if the primary problem is not in the gut, say the child has a mitochondrial dysfunction or a mercury toxicity or whatever it is, the gut is always going to be affected by it. And the gut is the one thing where, in order to stay healthy, to maintain your health, you need it to be in good functional order, because you need those nutrients to come in regularly. Throwing 50 supplements at a kid, and I'm exaggerating, I don't think I've ever eaten 50, but I mean, that's the criticism, we'll get, we throw all these supplements at kids, but even 4 supplements or 5 supplements, if you're giving it to a kid who's not absorbing them orally, you're not going to help them. Even if, intellectually you've figured out the problem, you've, worked it all out, you've done the testing, everything, you've got to get it into the kids. So that's always the first step, as we evaluate that. And I would say a vast majority of the kids have got issues. And sadly, even, the adults I see, the majority of the neurotypical adults have got issues in our society. And it's just, it's really an epidemic problem. So we start working with that. And while we're working on the gut, we'll do, say, a comprehensive stool analysis. Sometimes we'll treat empirically, depending on how strong, clinically the child presents. We'll try to get that into order. We'll start a workup as far as with labs. And some of the primary disorders that we're looking for is reasons why the child has inflammation in his brain, because that's almost always a component of it. There's a functional disconnection syndrome as well, which is a component, which is very important to address. But we always want to get the inflammation down first, because if you don't get the inflammation down, it's going to put a ceiling to basically all the efforts you're going to put in on the therapy end, whether that be functional neurological therapy, whether that be ABA, Sunrise, you name the therapy. You have to get the child, quote unquote, in good health, or as best of health as you can get them in. So that's sort of where we start off with. And then, based on how the child responds, what kind of labs we get, then we sort of take it into different areas. In some of these areas, the labs are, either emerging, or they're being developed, or they're not very accurate. So in some of these cases, we really just depend on how the child responds. So that's an area where there's been some great developments, like in mitochondrial testing, where we don't have to necessarily send them for biopsies anymore, although, in some cases we still do that. But yeah, I think the key element is figuring out why there's inflammation, and then in some cases where we don't know why, do. We have kids where we don't know what's going on. Unfortunately, everything we do, they're just non-responders. And those children, we do our best to sort of control it while we sort of keep looking. And those typically come out to be, in some cases, they're the syndromic cases. The syndromic cases are the ones where it's genetically mediated, which, in the media, if you listen to the media with this, they're always talking about genes, find the gene for this, find the gene for that. My experience is actually it's a minority of kids on the spectrum that it's really genetically mediated. And I'm not talking about like variants like MTHFR or something like that. That doesn't necessarily cause a disease all by itself. That's something that contributes to your disease load in your body. And so anyway, the syndromic cases where there's a specific gene that's driving that, those typically are a little bit harder to treat. Although we do still see response, it's just a little bit longer course than those.
So from the time that you first get someone into your clinic, what do you take small steps first, or do you tend to find that there's something you need to do in a big way right away to make that difference, and then start bringing that inflammation down and moving things forward?
I think it really depends on where the status is with the child, and also how the parent's preference really. When I first started doing this, I think I was a lot more careful about trying to find out what the exact problem was before I did the treatment. And, in retrospect, I think things went a little bit too slowly. And I've always been open to, kind of quote unquote shotgun approach. You just sort of cover all your bases because your goal is to get the kid better. I think as I've been doing this, over the years, I think I'm embracing that sort of broad-based approach a lot more. And the reason for that is we're kind of fighting the clock because we really want to elevate that child's function at as young an age as possible. And, it's nice to do the elimination diet, one food at a time, and then do a supplement every 3 weeks and do a controlled look to see which one is doing this and that. And that, that's good medicine, right? And if you're dealing with an adult who has a chronic disease and he's not developing, that's probably the right way to do it. It takes a couple of years, but what's the difference between 42 and 44? Well, not much, at least not for me, it wasn't. But what's the difference between 3 and 5? It's huge. So, that's where I'm always torn, because frankly, the other way is a better way to do medicine, but we do lose valuable time in the child's development. So I'm definitely more partial to the broad-based approach if the parents are open to it. And most parents are. Most parents come to see me because they want their kid better. And I want their kid better. So yeah, usually we'll kind of just throw it all out there. And I explain this to the parents. I'm like, look, we have a higher chance we're going to get your kid better, but I may not be able to tell you exactly what the problem is. I'd rather get the kid better and then figure out what's going on, and by peeling things back. I'd rather than peel back some sort of intervention, see if he regresses, and then, oh, okay, we were onto something there. Because now we gain this valuable time, where the child, he started speaking, at 3 or 3.5 instead of at 6 or 7. The cool thing with kids on the spectrum, really, their plasticity in their brain, I'm continually impressed by it. I think they maintain it later in life. I think, I'm forgetting her name now. She's the autistic adult.
Temple Grandin.
Yeah, Temple Grandin in her book. She wrote how, she felt her brain was more plastic as far as her learning things into her 30s. I've experienced that myself, in my own son and in my patients. So it's not the end of the world if you lose some of these kind of valuable windows. But that being said, a 3-year-old brain's still a 3-year-old brain. So, you want to get that fire taken out as soon as you can.
Yeah. So when you talk about, so you're going to do gut healing, and part of that is food and what foods are sent out. Do you use any testing to determine what foods? So, because if you're not going to do a slow elimination diet, typically you need to figure that out, or do you use broad-based dietary plans to do that?
It depends on the kid, but generally speaking, if I have a high degree of suspicion for leaky gut, well, the one thing I tell the parents first off is gluten-free, casein-free, soy-free, unless there's a few instances where, we go around that, but generally speaking, we start off with that just because those are so common as far as causing food sensitivities. As far as at what step do we then do food sensitivity testing? I don't always do it up front. If I have a high degree of suspicion that there's dysbiosis, leaky gut, all these other issues, I don't do it right off the bat because it typically kind of just lights up everything. So as far as multiple foods, getting a test back and then telling a mom, eliminate these 25 foods, that's not very helpful, right? I mean, the parents just wasted, $275, in my opinion. So in a case like that, we'll actually do some gut work. We'll do the basic eliminations, your gluten, dairy, soy. And then when we're getting some, the stools are more formed, the kid's less bloated, he's not, pushing his abdomen against a chair all the time, trying to relieve the pressure. If we're seeing those kind of improvements over the course of a few months, sometimes we'll even do a follow-up stool test, to confirm that there's improvement. If clinically the picture's a little modeled. At that point, then sometimes we'll do the food sensitivity test then. In other cases where the child's GI symptoms are more mild and maybe it's just the food sensitivity without the other issues going on, and then then a lot of times we'll do those up front. I like using the KBMO test. That's the food sensitivity test I prefer. When I got into this, food sensitivity tests have been a thorn in my side for a long time because they'd create more questions than they would answer, in my opinion, because you would have so many foods light up. There were so many false positives. I'd have parents, they'd have a 2.5-year-old that were concerned they didn't want to restrict their diet too much, so they would, get this food sensitivity test, and I would come back and tell them to eliminate 20 foods. Mm-hmm. It just wouldn't be that helpful. So I actually stopped doing them altogether for a while and just did elimination diets, which are frankly more accurate than any of the food sensitivity tests if they're done right, but they're a lot of work for the parents. And sometimes it can take a fair amount of time to get some answers. The KBMO test, by the way, I don't work for KBMO. I have no financial relationship with them at all. I wish I did, but I don't. Because it's a great test. That's why I wish. But what they did was, instead of just checking IgG, which is what most of the food sensitivity tests do, they also checked another component of the immune response called complement. Complement is this very primitive part of our immune system. It's essentially one of the main reasons you feel crummy when you get the flu. When it turns on, it's on. Something is different because you feel different. So when you see it turned on to a food, it's a lot more likely that it's going to have some sort of clinical relevance. Whereas when you just see IgG lit up, maybe it has clinical relevance, maybe it doesn't. So what I saw with this test was I was getting back tests that were showing, 4 foods, 5 foods, maybe 6 foods. And that sounds like a lot, but frankly, out of those 4 or 5 foods, one of them would be like pumpkin or pineapple or something that was not a staple food. Usually would have 1 or 2 staples. So it was a lot easier for the parents to follow. And on top of that, we were getting good response with it. I think I've run probably over 60 or 70 patients on it now in the past year. And it's actually changed the way I practice, because now I've gone back to using the food sensitivity testing because I found it very effective. So.
Yeah, I think you found what lots of people find is that the food sensitivity testing is hit and miss, and when you find one that find that works really well, it can be really helpful. But getting a list of 30 foods is not really helpful to anybody. So
it's nice. It usually confirms that the kid has leaky gut. But, that's a pricey test for confirmation of one thing, in my opinion.
Yeah, no, I completely agree. So one of the things I was going to ask you about is in the comprehensive stool analysis, what are the types of things that you're looking or you're seeing with these kids being fairly common? I mean, not everybody knows what all the markers are. They just think we're looking for yeast and dysbiosis, general dysbiosis and parasites. But what else can we glean from having that kind of testing done?
Well, definitely what you had mentioned as far as like yeast and dysbiosis, those are important. Dysbiosis is a little tricky to look for because we don't exactly know what a normal gut microbiome is still. I would say every year we have a better idea, but we do know certain keystone species which are supposed to be there, like lactobacillus, bifidobacter, and so forth. So we definitely look for those. The best tests I found are the ones that will actually culture it and do genetic analysis, so you kind of get both. Because sometimes it won't culture out, but you'll see there's genetic fragments of it. And sometimes it doesn't really work the other way, but that's one thing we definitely look for. I like going through the list of all the commensals that should be there. And when I see too many highs or too many lows, that's usually indicative of it, especially if you have certain keystone species that just are not there. And I'm not talking about culturing out, I'm talking about genetic fragments, which is very sensitive for that kind of stuff. That's one component. Outside of the, and then obviously any pathogens like Pseudomonas or there's a load of different pathogens that those need to be addressed. I like looking at EPX, calprotectin. There's a secretory IgA. Those are all different markers of inflammation in the gut or immune activation. Those are important in terms of, you're not really supposed to have immune activation in your gut if there's not a problem there. So in a person who supposedly doesn't have any problems in their gut, the immune system shouldn't be activated beyond what a normal level of activation is, just from tolerance of the good bugs there. So when we see those elevated, those are big. The byproducts from the bugs are important. Those would be your butyrate, propionate. They're all short-chain fatty acids. Commonly we'll see butyrate levels quite low. Butyrate's a really important short-chain fatty acid in terms of it's a natural antifungal. It's a wonderful fuel for mitochondria, for energy production. We don't really get it from food. There's some in butter, there's in a few other foods, but it's very unstable. So it's not commonly found in foods. Like I said, there's a couple out there, but the majority of the butyrate that we get is made by our bugs. I think the other implication of the bugs also is in detoxification. Everyone always talks about detoxification and how important it is, and we always think of the liver. Some of the research coming out now shows, with a healthy microbiome, they're picking up at least half of the body's detox load, which really takes a lot off the liver, because the liver doesn't just detox, it has lots of things it needs to do. So if that's the sole form of detox, there's only so many resources in the body, something's got to give. So, but I'd say those are the main elements. I mean, there's a lot of nuances, I think, to comprehensive stool analysis. We also look at, they're doing zonulin testing now on a lot of them. I don't know. I think I'm not sure what to make of that. I think it's still relatively new. I love the idea of it as far as being a marker for leaky gut, but I'm not quite sure how accurate it is, because my understanding of it is it can change throughout the day depending if you get the poop in the morning versus the afternoon versus what type of meal it is. So I do still order them because a high result is still helpful. But sometimes I'll get a normal zonulin and the kid's got every single sign of leaky gut otherwise, so clearly he still has it. So, but yeah, overall it's an indispensable test. And it's also good for tracking when you're trying to rebuild somebody's gut and reset their gut. It's invaluable to see that the work you're doing is actually helping. We have some kids that just probiotics, they don't seem to stick. They just pass through it. And I would say probably most people, probiotics they're helpful as a therapeutic agent, but they don't really change the microbiome much. We see a lot more changes in the microbiome with dietary changes, with giving prebiotics, which are indigestible starches that the bugs eat. And when we do gut resets, we do a combination of it all. We also give prebiotics, we also give probiotics, we give prebiotics, and we encourage fermented foods if they're not yeasty, of course. If they have yeast, then we can't do that. So.
Yeah. So once you've done the work on the gut, or at least you have it in progress, what's sort of your next steps with the kids?
So once we have we're doing it kind of concurrently. So while we're doing all the gut stuff, we've already sent out labs or doing therapeutic trials with various supplements or interventions, as far as supporting methylation, mitochondria, and whatnot. And and that's the part where I said earlier with the broad-based approach versus the targeted. So when we're doing the broad-based, the kid starts getting better.
Mm-hmm.
And sometimes it's hard to say, is it because we did the gut stuff versus the other? So once things kind of stabilize, usually I'll try to get a confirmation of what's necessary. Because the last thing I want, with a broad-based approach, we usually start the child on a lot of different interventions initially. But I don't want a child on 20 supplements for 10 years. And I mean, if they need it, they need it. But I think it's the rare child that actually needs all that. I mean, from my experience, what I've seen is once we get them healthy and we kind of whittle it down, most kids, they usually need 2, 3, maybe 4. Just, we target to where their unmet need is.
Mm-hmm.
A lot of children on the spectrum, that unmet need happens to be with mitochondrial support. That's very common in that population. A lot of them have, what I call an autoimmune disposition. I can't say they actually have autoimmunity because I think there's a large subtype of autism that's actually autoimmune. It just hasn't really been defined. So it's not kind of officially an autoimmunity, but we'll see other kind of soft autoimmune markers in the blood that support that. For those kids, we will do immunomodulation, where we can either do it with herbs. We do something called low dose immunotherapy kids, where it's like it's basically a form of homeopathy, where we actually dilute the antigens to quite dilute levels, far more dilute than what you would get at the allergy therapy at the allergist's office, and we actually get pretty good results with it. So we try these different things based on what we suspect the main pathology is behind the autism, and then we just try to refine it. Usually after, it varies with each kid, but anywhere from 6 months, maybe 9 months, most of these kids will need some form of detoxification, and that's usually when I kind of start looking at that. I'd love to be able to do it right up front, but when you have all these other problems going on, the child's they're just not going to tolerate it. So we have to wait on that until the child is ready, because the detoxification is, we always think of detoxification as these external things we're adding to the body. They're not. The majority of them really they're just different interventions where we're supporting the body's natural detoxification pathways. So in order for those to work, we need to make sure we've met all their unmet needs, and we've fixed their gut so they have good nutrient flow, make sure they have enough energy from the mitochondria, make sure their immune system is kind of settled down, it's not dysfunctioning. We have to do all those things. So if we detox too early, that's actually where the child could even go the wrong direction and start regressing. So.
Mm-hmm. So when you do get into detox supports, what types of detox supports do you like to do, and have you been using in your clinic?
I tend to go probably a little bit more gentle routes. I'm not against IV chelation by any means. I don't do it in my office. I refer out to that. But that's definitely one. I think that's a more aggressive one. What I usually start with, though, is what I want to do is make sure that the child's own detox pathways are working to their maximal efficiency. Now, if we get them to their maximal efficiency and then, things aren't going the way we want to, that's when I start kind of looking at the more invasive type things. I use the ion cleanse foot bath. I use that pretty extensively, actually, and I wasn't using that at all a year ago. I can't go into the details of it, but I mean, we're investigators right now in one study with that, and I can tell you that, without revealing too much, the preliminary results are very, very exciting. It works, and and it's got nothing to do with the yucky water and the foot bath. It's all happening actually a couple of days later, because essentially what that device is doing is it's supporting the child's inherent detox pathways through it's using the feet as a positive and negative electrode to send a very small but very specific current that upregulates their detox pathway. It's almost like a form of electroacupuncture, I guess you could say. We had a lot of good luck with that, and what I like about it, because one of my big rules in my practice is, we don't make kids worse. I mean, I'm very, very, very careful with the kids. And again, that's, like I said, I'm not detracting from some of the more aggressive interventions. I think some kids need those. Mm-hmm. And but I'm going to try all the other stuff first. With my autoimmune adult patients, I tell them I'm not against Enbrel and Humira and all these biologics. Sure, they have a place at the end. Mm-hmm. There's all the other less invasive, less side effects, and less dangerous things that we do first. And I treat detox the same way. So.
No, and as you know, I've spoken with, and we'll be speaking with more people about the Iron Cleanse over the course of the summit. So we'll get more into the details of what's been happening with that. But one of the things I do like about it too is that it appears to be supporting those detox pathways that just allows the kids to just upregulate their detox systems. So aside from that, what other types of, so you've looked at gut and the diet and immune modulation where that's been necessary, upregulating their detox and then supporting that. What other types of therapies do you use within the integrative model within your practice that you really think are nice to be able to do if you can?
I like the functional neurology rehab programs. I actually find them to be essential in recovering kids, or at least getting the kids better. And when I introduce them to the families varies. Sometimes it's at the very beginning. If I don't feel that there's too much pathology getting in the way. Sometimes we wait a little bit to introduce it. It also depends on the age of the child, how compliant they're going to be. Some of these exercises, some of them can be quite intricate, and you need the child to cooperate. So, but yeah, I think those are an important part. And as far as how the parents do them, there's different ways to do it. There's centers where you can go and they have these, 6-month packages, and they have a therapist do it for you. It's one way to do it. There's ways where you can have a physician working with the parents to train the parents to do it at home. I'm actually partial to that if the parents have the time to do it. It's hard. But, for us parents with kids on the spectrum, everything's hard. So it's a little bit more hard. There's nothing easy here. So I think that's probably the most valuable, because as long as the parents are trained well in terms of how to do it, the child's going to respond best to the parents, in some instances, or most instances, I think. And in some of the older kids, some of the teenagers, we've actually got some of them to motivate to do it themselves. Where they don't even, because truly, actually, you don't really need, if the child understands how to do the exercise, or the adolescent, I would say, in this case, they can do it on their own. You just have to motivate them. Motivating a teenager is probably the subject for a whole other podcast, I would imagine, but that's probably a bigger challenge than anything. But yeah, that's a huge part. And I always tell the parents, all this is for nothing if there's no stimulation. Synapses, neurons, you want to grow new synapses, you want to get new connections in your brain, you have to stimulate it. But there's no pill in the world that's just going to do it by itself. So what does stimulation mean? It means therapy. And that therapy, that can be functional neurological therapy. Preferably, it should be a combination of multiple therapies. The kid should be in ADA or Sunrise, or there's lots of different therapies. Neurofeedback's great. All those are forms of stimulation, I think, that are very important. I want to backtrack a little bit. One thing I didn't actually mention was ruling out seizures. As far as in the work of it, just slip my mind there for a minute. That's actually a big part in a lot of the kids. Usually before we see the kid, they kind of have the conventional workup. They saw the pediatrician, and the neurologist. A lot of times the neurologist will do, at best you'll get a 24-hour a lot of times they'll do like a 1-hour EEG in the office, and half the time they'll sedate the kid for it. That's just not, that's not adequate to rule out seizures. That's you know, when you sedate a child, I mean, you're changing the brainwave activity. So you really want to get a 24, even 48-hour EEG where the child goes home with it. You know, one of these portable units. There's some vendors out there that are excellent with this. Actually, they've got little, you know, things that cover the kid's head, and then, you know, cool little like Toy Story backpack they wear, and you basically take them home and you do whatever you would do with them for a day or two. And because again, that's another one of these ceiling effects we're talking about, where if the kid is continually having seizures, and a lot of seizures are not obvious. You know, we think of seizures, we think of a kid on the ground shaking and foaming at the mouth. That is not how a lot of these seizures present. A lot of them are absence seizures or tonic-clonic seizures, where it's just a jerk of the arm or the kid staring off or something like that. If they're getting these episodes, if they're getting multiple episodes of these a day, it's going to put a hamper on all treatments, you know, as far as moving forward, whether it be therapies or trying to, you know, rebalance, you know, physiologically, whatever it is. So I think that's an important thing. And again, where we place that in there depends on the kid, but sometimes we do it right up front, but invariably at some point, especially if we're not getting anywhere with the other treatments, you know, within a few visits, I mean, we definitely want to evaluate that and make sure that that's been addressed, if that's indeed there or not.
And how important is it in terms of finding the right person to read the EEG? Like how do parents go about making sure that they have had the proper assessment? Like you said, usually there's too short, but also the physicians that aren't as familiar with how the patterns work with these kids often dismiss some of the readings.
I think it's hugely important, because what winds up happening is a lot of neurologists will read, they're sort of like on an EEG, you know, there's these squiggly lines and they interpret them in different ways. There's sort of a classic seizure pattern on it that any neurologist who's been trained will pick those up. That's not, you know, if the kid's having those, well, yeah, then anyone that could be picked up. But a large chunk of these kids are not having the classic pattern. And what they're having is this sort of intermediate. It's not normal, but it's not a seizure. So unfortunately, when a lot of neurologists read this, they just sort of say, well, you know, it's just abnormal activity. Mm-hmm. Well, you have a kid who's neurologically limited and neurodevelopmentally delayed. Oh, it's just abnormal activity in the brain. Well, that's pertinent. I mean, you know, the child's clinically expressing it. You know, maybe if you saw that in a kid who's developmentally perfectly normal, maybe you could blow it off or just monitor it or something like that. But in a child who actually is having neurological issues and neurodevelopmental delays, any abnormal activity needs to be investigated. So there are some epileptologists who are trained to sort of look at the finer gradations of these. So there's a company we use here. I'm in the Southwest, and they're based out of Irvine, California, called EEG to Go, and they work with this epileptologist who's very good about interpreting those. And there's other ones in the country as well, and they usually are with a kind of mobile EEG outfit, and they usually focus specifically on children with epilepsy on the spectrum. Like I said, you know, there's estimates up to 80% of children on the spectrum have some form of seizure activity. Mm-hmm. That's on the high end. There's, you know, lower ends too, but it's a lot. We're not sure exactly what the number is, but it's a lot. So yeah, I think it's really important. Number one, to get the length, a good quality study that's long enough to capture awake and sleep, because some of these kids only seize in their sleep. And the other one is also who's reading it. So, and usually if you go with a mobile EEG outfit that's specifically focused for kids with epilepsy or on the spectrum or anything like that, at least from my experience, that they usually are kind of partnered with a good epileptologist who can interpret those well.
That's fantastic. So aside from, and I'm really glad you jumped back to that, because that is a big piece for a lot of parents. And I've encountered several parents that thought that they had that looked at and then realized when they had looked at again that it was missed for a really long time. And that's a real shame. So thank you for going over all of that. You've also talked about, the functional neurology and all the different types of movement therapies. Are there any other ones in your clinic that you have used that you really like to do as another layer when the patient or if the child was ready?
Well, yeah, we didn't talk about hyperbarics.
Mm-hmm.
We have a chamber here in the clinic, and we use it fairly extensively. Again, it's variable when we sort of plug it into the child's treatment. But really, I mean, unless there's a reason you can't, like, the child's claustrophobic and is going to tear apart the machine, and or they have sinus or ear issues, because when you pressurize, it's like going on a plane, especially if you have a child who can't communicate, and they can get some significant pain from it. So there's some instances where it's not appropriate, but I think all kids benefit from it to some extent. I mean, I'm a big believer in it. I jump in the thing myself when I get a chance. I mean, stops me from getting sore after I go to the gym, which is kind of nice. I mean, if I can spare a few hours there. Yeah, I think it's a great modality. And as far as when to plug it in, though, that's again, it depends on the child. But yeah, I'm a big fan of that, and I think it helps. And I think it helps a lot of ways. I think it helps in different ways than people realize. I think there's so many different ways that it benefits. I mean, I think one of the ways that it benefits is, it increases the oxidative stress in some cases, and causes the body to make these increased compounds to sort of extinguish that. So it sort of and a lot of kids on the spectrum don't make enough of these compounds, because we all have oxidative stress. That's oxidative stress is a simple way of putting it is rusting. We're all rusting. That's the price we pay for breathing oxygen, for being alive. So we have things in our body that counter that, but they don't counter it forever. After about 90, 95 years, they don't work anymore. But we have, we kind of have an expiration date on that. But in children, they should be working pretty fantastic. And a lot of the kids on the spectrum, they're just not working that well. Sometimes by pushing that stressor through the hyperbarics, we can actually make that work better. There's also evidence that it helps as far as rebalancing the microbiome. There's evidence that it helps burn off very long chain fatty acids, which is a whole other issue with the membranes and how the membrane is structured. You get these very long chain fatty acids that are very hard to burn off, and the hyperbarics can help with that. So yeah, hyperbarics is kind of one of these. It's almost a broad-based approach in and of itself. I think another thing I didn't mention either was sort of the injectable nutrients, your B12 and folinic and NAC, those kind of things. Those I use actually fairly heavily in the beginning, especially when I think the child has the gut issues, but we want to start moving the treatment forward, because we don't have to worry about the gut. We can bypass it, and we see these nutrients. These unmet nutrient needs, they're extremely common in our kids, and we bypass it. Most compounding pharmacies, have no problems making it. I think there's some restrictions in California now, but I think outside of California, most places, I don't think it's a huge issue. But yeah, we've had a lot of luck with those as well.
That's actually good one to talk about, because a lot of the first steps that a lot of the practitioners use are the methyl B12 in particular is suggested for a lot of the kids. So just to sort of wrap up here, what would you say to parents that are just getting started out, or they've been at this for a while and they're kind of frustrated or overwhelmed with what they've been doing up to now? What would you tell them when they first came into your clinic?
If they've already started a functional medicine treatment, or they haven't?
Well, I guess both. So what do you say to the ones that are just starting out, and those the ones that have been there, done that, and haven't seen everything they're looking for at this point in time?
I mean, first off, for the ones that haven't really tried any of this on their child, I sit down and I explain to them that their child has a medical problem. There's a physiological imbalance. Their child's not crazy. Their child isn't, it's not a psychiatric problem. It does present as a psychiatric problem. Yes, that's a symptom. The problem is, the core issue is that there's some imbalance somewhere in the body, and we need to find it and rebalance it. So I focus on that first, so they can, view their child differently, as far as, this is not necessarily a lifelong condition. We never make any guarantees of recovering children. There's no such, you can't do that. My son's a lot better, but he's not recovered. Recovered other kids. It's probably the hardest part of my job, I think, is sometimes, being able to recover another kid, and I can't do my own because each kid is different, what you do. But we can get most, if not all of them, better to some extent. And that's, what do we want from our kids? We want them to be the best they can be. And, if you want your kid to be a swimmer, that's great. That's great if they win an Olympic gold, but if they're just good at it and they enjoy it, or even if they're not good at it and they enjoy it, that's good enough, right? So that's the first thing, is I try to change that mindset. And, the second thing I do is I tell them, especially if they're frustrated, is they have to have hope for their child. Because as the parent, they're the ones who have to have the hope. And if they don't have hope for their child, then I don't know who else is going to do it. So, and as a parent, you have to be this eternal spring of hope. Have to, and it's hard. It's hard, especially for we get kids that are non-responders. We do everything. We try everything, and nothing seems to work. And in a few cases, they even get worse. We don't see that often, but we see it, and it's hard for those parents because they're putting in all this time and energy and money, and it's hard to keep that spark going. But I just tell them in this case that there's some secret sauce we haven't found yet, and we just have to keep looking because there's something going on that needs to be rebalanced. And the commoner issues, okay, in this kid, that's not what it was. So I try to revitalize him, and I understand the part about frustration. I've been there myself with my own son. It's been a rocky road with him. So I definitely feel for them. But you just have to keep it up, and also realize that there's not something where if the kid's not better by 5, forget about it. No, absolutely not. I have young adults I see here, and we get them better. You can always get better. As an adults go to the doctor, and they get better. So why would this not work for I should say kids, for individuals on the spectrum? Of course it does. Because at the end of the day, nobody's going to be at their best if they're sick. And that's where it's really simple. It boils down to, we need to make your child not sick is the first step. And then once they're not sick, then their brain will work better, and they can start learning these things that they haven't learned, like speech or reading or writing or potty training, or whatever the delay is.
Yeah. No, I think that's sums it up really perfectly. So thank you for that, and for all your time today, because it's been a great breakdown of what we can expect when we go to a functional medicine practitioner. Having an idea of what all that means when you haven't been to one before, or even if you have encountered but haven't had the full experience yet, it's really, really helpful to be walk through it step by step. So thank you very much for your time today. And I hope we get to do this again soon.
Okay. Thank you for having me, Tara.
Thanks.
Bye.
Bye.